I'm Dr. Amit. I'm an orthopedic surgeon specializing in sports medicine. I've been in the Phoenix area practicing for about 3.5 years now, and I work at the Arizona Sports Medicine Center, which is a division of OSNA. I have a special interest in ACL reconstruction. First, a little bit about the anatomy of the ACL. It's one of 4 ligaments that are primary or main stabilizers of the knee. It runs from the femur or thigh bone down to the tibia or shin bone and provides stability both in terms of front to back as well as rotational or side to side. Unfortunately, when one tears their ACL, the ACL does not heal itself. And so if you are an active person, very often you need to have ACL reconstruction so that you can regain or retain the ability to participate in high-end sports, including any sports that require side-to-side or pivoting stability. A specific issue surrounding ACL reconstruction is what is the age limit that somebody can be to have an ACL reconstruction. Historically, we used to stop around the age of 40 because we felt that people over 40 were not super active and did not require a rotationally stable knee for participation in activities. Well, things are changing. As our baby boomer population ages, so does the generation behind it, but this generation is more active. And so I was involved in a study when I was a fellow that looked at should we or shouldn't we do ACLs in people over 40. I found that people who were active, skiers, basketball players, whether they were professional athletes or weekend warriors, tended to have happier lifestyles, better outcomes if you did the ACL reconstruction, stabilizing their knee, and allowed them to return to sports. On the same line, that actually delayed their development of arthritis, which delayed the theoretical need for getting a knee replacement in the future. Another issue with ACLs is historically we used to reconstruct the ACL such that the tunnel that was drilled in the thigh bone was at the 12 o'clock position. If you imagine the part of the thigh bone looking like a clock, then we used to drill this tunnel straight up and down. Anatomic studies have shown that the true attachment point for the ACL is really further down along that clock face, more around 9:30 or 10 o'clock. I still see orthopedic surgeons doing ACL reconstructions with a tunnel at the 12 o'clock position, and I think that leads to a higher rate of failures or a less promising outcome after surgery. Finally, a third issue surrounding ACL reconstructions is what kind of graft do you do? There are 3 main choices for ACL reconstruction grafts. First is patellar tendon autograft, which is taking your own patellar tendon. The second is hamstring tendon autograft, which is taking your own hamstrings. And the third is allograft or cadaver tissue. There are some risks associated with allograft tissue, certainly one being risk of infection, but that's pretty low. The bigger risks that I've seen in the literature are quicker rate of loosening, higher rate of instability, higher rate of failure, and in some anecdotal studies, particularly in adolescent girls, the graft essentially dissolves several weeks later. And there is no evidence of ever having had an ACL reconstruction, so you have surgery but still end up with an unstable knee. Second choice would be patellar tendon, or taking your own patellar tendon, which goes from your kneecap to your shin bone, taking the central third of it. And while many still consider that to be the gold standard for ACL reconstruction, there are some potential risks and complications associated with that. One being a high rate of anterior knee pain, and the other being risk of patellar tendon rupture and patella fracture. Third option would be hamstring autograft, or again, taking your own hamstring tendons from the medial side of the knee. That's what I tend to choose in my practice because I find that taking your own hamstring tendons gives you as much stability after an ACL reconstruction as either patellar tendon autograft or allograft, and it doesn't have the risks associated with the other two.